let's shift away just for a moment. One of the new kids on the block is T-VEC, and right now approved in the U.S. as monotherapy. Jonathan, you mentioned before that patients with intransit disease, for example, might be candidates. So what do you think of as the, let's say, multiple potentially scenarios where before systemic therapy becomes the focus that the T-VEC would play a role?
Well, I mean, I particularly use it in the 3B, 3C population, especially patients with lower burden of disease that's not rapidly progressing. I think the phase 3 trial was positive, obviously, with durable response rate 16.3% versus 2.1% in favor of the T-VEC group. And again, like I mentioned before, it's extremely well tolerated. It's fast. I can give it to patients usually in 5 minutes. The patients tolerate it very well. The side effects are not unlike some of the side effects you guys have already described, but mild to moderate flu-like illness the night of injection, maybe the following day, that usually responds to Tylenol, and then they're better. And then as you go along in treatment, with each subsequent treatment, I think those side effects get less and less to the point where some of my patients aren't having any side effects at all.
Yeah.
So for moderate to less disease burden that's not rapidly progressing, stage 3B, 3C, especially in patients who have contraindications or don't want systemic therapies, I think it's a great option for them.
Yeah. And Jeff, when patients who are on immune therapy, could have been PD-1 CTLA-4 combo followed by nivolumab maintenance, or just PD-1 monotherapy, if they have injectable disease that let's say persists or appears, sort of oligo-progressive disease, not a lot, does T-VEC have a role there?
If someone has isolated progression during and after immunotherapy, I'll always try to have it surgically resected. If it is not easily resectable, and as John appropriately points out, resectability is always in the eye of the beholder. Right. Yes, I think that a direct injection therapy, I think would be reasonable. That's a very small niche population. I think T-VEC alone, again, is somewhat of a niche drug. I see the value of an oncolytic virus like T-VEC, and by the way, a couple others are coming along in earlier trials. I see the value of those drugs as a way to prime an immune response in a patient who then would subsequently receive either PD-1 blockade or combination blockade. So and there's an ongoing phase 3 trial, as I remember, with Pembro T-VEC versus Pembro alone. So I see that as the value, and if that's a positive study, I think you're going to see a lot more traction, a lot more use of T-VEC.
Yeah.
I would venture a guess it has a modest utilization now in the U.S.
Yeah.
Since we have very good drugs, it's just, like I said, a niche agent.
Yeah. So Jeff was mentioning surgery for oligo-progressive disease. What do you think about the role of surgery for patients who've had a partial response, but still have some disease that remains? And here I'm mostly thinking of visceral metastasis. At what time point, as a surgeon, you're being asked to consider this patient 6 months in, 12 months in. How do you react to that?
Again, if the bulk of the disease has gone away, it doesn't matter with combination targeted therapy, single agent, immunotherapy, and there are isolated lesions. Jeff and I have collaborated on this many times. I'll go ahead and resect and make the patient NED, and I think that's the best thing for the patient. Sometimes you have these resistant lesions or some sort of mutations that happen, and they're no longer responding to the systemic therapy, and that's a perfect candidate to have as clean-up surgery and make them no evidence of disease. Yeah. We did it plenty when Jeff was in Florida.
So the key there you just mentioned was resistant lesions. So just a question, because our surgeons, we sort of discuss this. If we've got a great response, but there's one lesion that's growing or showing resistance, our surgeons are very keen to help us out and cut them out.
Yeah.
However, if they've had a great response and it's just a residual lesion that's not changing, they won't necessarily go in and cut that out. However, if the patient's keen to understand what the disease is and we're collecting biopsies for research to understand what the nidus of tumour is, then we'll go ahead. But what's your approach on that?
If you have 10 lesions and there's one lesion left over, changing or not, I think we should resect it, as long as it can be done with low morbidity. Of course, I wouldn't do a right
Liver.
hepatectomy,
Yeah,
exactly, for one stable lesion, because that's an operation that can have some morbidity. But if it can be done with relatively low morbidity and the patient understands the risks and benefits, then I think it's absolutely appropriate to resect a stable lesion that's just hanging on.
Just one
I
more question on
agree.
that spleen. How far do you go? Spleen?
I take out a spleen.
Okay. Adrenal gland?
Yeah. Yes,
No,
adrenal and
I
spleen
agree with
are-
John. I don't understand the rationale, unless it was absolutely cold on a PET scan, or you were somehow convinced it was a necrotic dead mass of tissue with no tumor. If I can make a biblical paraphrase, if it offends thee, pluck it out. I would take it out.
Yeah.
So that's another key. We do that. If it's PET hot, we'll take it out.
Yeah.
But if it's PET cold, so you've had a patient who's had a great response and you can see these little lesions in the liver and elsewhere, and they're all PET cold, we just watch.
Little lesions we'll watch too. So
Yeah.
little lesions and more than 2 organs at least. Obviously, we're not
Yeah,
going to go in and
yeah.
do the spleen and
Yeah,
adrenal.
yeah,
But 1 adrenal, 2 centimeter met, that's the liver's now clear of disease, and there's an adrenal gland that still has this stable disease. That's a low morbidity operation laparoscopically, and I think we would go after it.
But
Great.
again, there's mineable data here. You see, one of the interesting things about having a large number of patients that have been on randomized, well-done phase 3 trials with, either Nivo alone, Pembro alone, the combo, or Dab-Trem or Cobi-Vem, is to mine these sorts of trials to get this information. What happens to the 80 patients who had a single-sided disease left that was resected? If they all relapse very quickly, then maybe we shouldn't be doing surgery. But I would venture a bet they would do extremely well.
Yeah, I think so.
But we need to know.